Professor Dame Til Wykes, many thanks for taking part in this Spotlight video. Can you tell me a bit about your background and your work at King's College London?
Okay, well, I've got lots of different hats. So I'm a jobbing clinical psychologist, and that's my general background, but I'm also a scientist. So I do research into developing treatments for people, mainly those who have a diagnosis of schizophrenia. But I also have an interest in digital health and how we can make digital products like apps more useful and acceptable and effective for people with mental health problems. And in addition to that, I'm also doing administration, as all of the senior scientists do. So I'm also the Vice Dean for Psychology and Systems Sciences at the Institute of Psychiatry, Psychology and Neuroscience here at King's College London.
Thank you. And the reason we'd like to talk to you today is to discuss the role of digital therapies for mental health in the current pandemic and beyond, and how, I guess, in a time where so much is being done remotely, this is an area with plenty of potential, but also one where we need to make sure we're doing it right. And in a recent editorial in JAMA Psychiatry, you wrote about how the pandemic is providing challenges and opportunities for digital therapies for mental health. Can you explain what these are?
Well, there are lots of different kinds of therapies, and they range really from a sort of online video face-to-face therapy, which is what many people have begun to experience, as we haven't been able to speak face to face. And then you just see your therapist in the usual way, except the usual way now is at a distance and on Skype or Teams or Google Hangout or Zoom, one of those digital platforms. So although we're doing it separately, the same sorts of therapies are being used in that talking therapy way. Now, that's the easiest currently, but there are also other kinds of therapies that we've done, which is to have a blended therapy. So that means you have some face-to-face time, some computer online time, and extra to that is an app, which you might carry around and have open most of the day, which helps you to do homework. Here at the Institute, we have something called slow-mo therapy, which does exactly that. So that's for people with a diagnosis of schizophrenia, and they have briefer and less of the face-to-face sessions, but in between that, they do this homework to help them to put into practice the things that they are learning about online. Then the next one is really moving completely away from having a therapist. It's having a therapist in your phone. So it's when you have an app, or it could be online therapy as well, providing you with some ability to help yourself and learn new techniques that you might try out. And sometimes in those apps, there is a remote person who might be watching over you to sort of moderate that, the things that are happening to you, or might give you a hint or two. But mostly the information is held within the app and is used by a program, usually governed by something called artificial intelligence, which adjusts the program to the progress that you're making.
Great, thank you very much. And with so many people now at home and staying at home, there's clearly a need for digital health tools. And I guess many are in rapid development. How can we assure that they are usable, but also safe and effective?
Well, I think one of the things that we need to do is to make sure they are effective. And when you hear about how, in particular, the apps that there are, some people say we just copied other people's programs, we just did it in a slightly different way. Some people have clinical advisors who advise on how the program should be developed. Some just copied an online version of a therapy to an app. And that's a bit problematic because we use apps in a completely different way. You know, if we weren't in lockdown, we'd be using them on the bus or as we're walking up the road, and we may only use them for 10 minutes at a time. Whereas online therapies are usually more structured and can take half an hour to an hour to complete a session. Some actually say they tested it on users before they released it. So at least we know that people with that problem, anxiety or depression, can actually use the device. But I think the best way is to have users involved from the very beginning in the design and setup of the program or the app, and then to test feasibility with those people in order to make sure that people can use it, and then to do a proper study, a research study, where we test whether it's effective or not. That's important because these sorts of therapies are useful to some groups of people, but it's important to know how many people it doesn't help, because then if you happen to be fall into that group and you find an app doesn't help you, then at least you'll know that you're in a small group of people usually who are not helped by this and don't feel that somehow this is a sense of failure that you've got. I should say, though, that very few apps that haven't been developed within a university setting actually manage to go through all of those stages. Usually, if it's in business, there are lots of shortcuts taken before an app is launched onto Google Play Store or to the Apple Store.
Okay, so although we're kind of in a time of pandemic when people are wanting to do something quickly, what you're saying is there still needs to be very much this user involvement and research involved to make sure that these approaches are usable and safe and effective.
That's absolutely right.
Great. Yeah. And might there be any barriers with these virtual approaches in terms of uptake and engagement? And if there are, how can these barriers be overcome, both in terms of their development and their implementation?
Well, there are lots of issues around even the face-to-face video therapy that we don't really know. People are now investigating how we can develop a good therapeutic relationship, and a good therapeutic relationship will help people to engage more in the service, and they'll get more out of it. But we don't really know what difference it makes when we're actually online rather than meeting people face to face. Maybe there's some non-verbal communication, which is very difficult to give when you can only see people from the sort of neck upwards. And I think that is a bit more problematic, and we really do need to investigate that further. But there's a lot more about adherence. We know that people don't necessarily adhere to apps, for instance, they're sort of self-help, but they do adhere to them a bit more and they get more out of them if there's a human being involved somewhere along the line. And I think that we need to know what the dose is of that person having any input, so that we can actually make it as good as possible in terms of its outcomes for individuals with mental health difficulties.
Yes, that's really interesting. Thank you. And there still exists what's called a digital divide in society. So how can we look to make sure that everyone has access to these tools?
Well, the digital divide is reducing, but it's still there. And what the digital divide is that people may not have the skills to use some of these online activities. And in fact, I have had a very steep learning curve, and I've discovered that shouting at the computer does not help, although it's a bit of a relief when you're frustrated with not being able to do things. And there's clearly a lot of people who still feel frustrated about accessing and learning the various skills that you need for using these tools online. But there's also the issue of people being poor. We know that a lot of people with severe mental illnesses actually haven't got jobs. They may own a mobile phone, but they may not have any credit. It probably isn't a smartphone. And even if it's a smartphone, maybe they don't have a very good data plan. So the issue, and they may not even have internet in their house. So there are these difficulties which we still have to overcome. So particularly the skills and access to the resources that are really important. And we all need to bear that in mind, because we don't know how many people we're still going to have to phone up. So we don't even get a view of their faces, but we could phone them in order to keep on in touch with some remote therapy. Now, individuals may like some of this remote therapy. I shouldn't say it's all bad, because they don't have to get on a bus and travel somewhere. Although for some groups of people, particularly those who have difficulty leaving their houses, actually, the very fact that they have an appointment elsewhere they have to attend to is probably a good thing for them, and is almost part and parcel of the therapy itself. So there are some positives about this, but there are these barriers, and we do need to make sure that we cover all of those bases, including making sure they've got very good access to the internet.
Yeah, okay, thank you. And what do you think will happen in the long run? Will the pandemic produce this kind of step change in the level of mental health services done remotely? Or will we revert more to face-to-face therapies once this is over? I guess, how can we ensure that there's the balance of face-to-face and virtual therapies in the future, and that it's a good one?
This is a really tough question, because there's so much uncertainty at the moment. We rapidly changed to online and remote therapy, which was astonishing given all of the barriers that have been put up against it for years and years and years. And yet we are all now adjusting. We probably do need to have some face-to-face therapy, irrespective of whether service users want to have some remote therapy. I think if you talk to people, even those with the best internet skills, which is a younger population, they'll still say, I use my phone too much anyway. If I want help, I want help from a human being. It isn't clear how much of that human being can be provided, and that sort of social contact can be provided on this remote line. But I suspect we just need to get the balance right. We just need to know how much we can do online, and there may be some people in a staged way who will be offered this first, and then will be offered online face-to-face therapy later. And I think that's probably, it's a suck it and see question. We're all of us trying to collect data now about how much it's working and what people think about it. I think access to therapy is a really important issue. However, the health services maybe also be thinking about this as an opportunity to provide people with therapy when they don't have buildings enough to be able to see all the people who have mental health difficulties for extended periods of time. So it's a balance, and it will be a balance for the service providers, so the health services and the clinicians, and a balance for the mental health service users, who will be wanting to see people face to face, but also wanting to have easier access to therapy.
Wonderful. Thank you very much. That's been a great insight into this area. Thank you.
All right. Thanks a lot, Franca.